Welcome to our video on abdominal pain and acute abdomen. Let's begin. We'll be addressing different etiologies of abdominal pain by location of pain. We'll discuss the pathophysiology, then the etiologies that typically present with a right and left upper quadrant, epigastric, right and left lower quadrant, and diffuse pain individually. Lastly, we'll talk about acute abdomen. Let's talk a bit about pathophysiology of abdominal pain. Visceral nerves that innervate the viscera are sensitive to signs of inflammation. When there is presence of inflammation, the type of pain is described as colicky, dull, or diffuse. On the other hand, somatic sensory nerves innervate the parietal peritoneum. When inflamed, the pain is sharp and more localized with guarding. Mechanical distension also plays a part. When a certain organ or abscess ruptures, leakage in the peritoneum causes inflammation and ultimately causes an acute abdomen. Let's move to the etiologies of right upper quadrant abdominal pain. Common etiologies that present with right upper quadrant pain are presented on this algorithm. We will always start with a patient who presents with signs of abdominal pain. In every case where one arrives in the emergency department with hemodynamic instability, such as systolic blood pressure less than 90/60, tachycardia, or additional signs of shock or loss of consciousness, airway, breathing, and circulation come first, accompanied with emergent surgical evaluation. On the other hand, a hemodynamically stable patient can still go through several workups to get the diagnosis. Right upper quadrant pain can be accompanied with constitutional symptoms such as nausea and vomiting, as well as radiation to the right shoulder. It is important to obtain liver function tests, as well as amylase and lipase levels, since the liver, gallbladder, and pancreas are located in this area. Elevated liver function tests lead to a suspicion of hepatic pathology. However, increased levels of alanine transaminase, alkaline phosphatase, bilirubin, and gamma-glutamyl transferase, along with signs of jaundice, lead to possible biliary disease processes. If fever, hypotension, altered mental status, and a positive Murphy sign are absent, a right upper quadrant ultrasound is the next step, serving as a critical confirmatory test. A dilated common bile duct seen on the ultrasound gives an impression of cholelithiasis. On the other hand, a febrile patient with jaundice and a positive Murphy sign may need more workup, such as complete blood count, C-reactive protein levels, and blood culture in case of infection. Leukocytosis and elevated CRP may mean there is presence of infection, leaving us with an impression of an ascending cholangitis. This can be confirmed with dilated common bile duct seen on a right upper quadrant ultrasound or an MRCP, with biliary obstruction if results are inconclusive. Normal liver function tests and amylase and lipase can direct us to the etiologies seen on the left side of the slide. Absence of fever and Murphy sign typically directs us to an impression of cholelithiasis or biliary dyskinesia. These two etiologies can be differentiated with a right upper quadrant ultrasound, with cholelithiasis showing evidence of posterior acoustic shadowing or stones, while a biliary dyskinesia shows signs of biliary sludge. When fever and a positive Murphy sign are present, CBC, CRP, and blood cultures are also obtained. Leukocytosis and an elevated CRP can direct us to a diagnosis of cholecystitis with right upper quadrant ultrasound. The gallbladder wall is typically thickened with a collection of pericholecystic free fluid. If inconclusive, HIDA scan is used. If the gallbladder is not visualized, this confirms a diagnosis of cholecystitis. Let's try a question. A 45-year-old G5P5 woman is brought to the emergency department due to a right upper abdominal pain for 4 hours. She has had similar pain episodes in the past that used to resolve spontaneously. Vital signs are significant for a temperature of 39 degrees Celsius. Palpation of the right subcostal area causes pain on inspiration. Abdominal ultrasound is unremarkable. What is the best next step in the diagnosis of this patient? This multi-parous woman over the age of 40 complains of right upper abdominal pain for the past 4 hours. She's had similar pain episodes in the past that used to resolve spontaneously. These episodes are most likely consistent with the biliary colic. Vital signs are significant for a fever of 39 degrees Celsius. Palpation of the right subcostal area causes pain on inspiration. This phenomenon is known as Murphy's sign and is present in patients with acute cholecystitis. Fever further supports a diagnosis of acute cholecystitis rather than biliary colic in this patient. However, abdominal ultrasound is unremarkable. If the patient is suspected to have had cholecystitis but the ultrasound is unremarkable, the best next step in the diagnosis is HIDA scan. Failure of gallbladder visualization on HIDA scan suggests the cystic duct obstruction and confirms the diagnosis of acute cholecystitis. We're now moving on to etiologies that can cause left upper quadrant abdominal pain. When thinking about left upper quadrant pain etiologies, it is important to keep a splenic or lung pathology in mind. Patients without hemodynamic instability gives more time to finalize a diagnosis. Absence of respiratory symptoms such as cough and dyspnea can rule out a pulmonary pathology. A splenic pathology may have vague symptoms, but a tender abdomen associated with left shoulder pain are classic characteristics. Constitutional symptoms such as fever, nausea, and vomiting may be present as well. Further workup with CBC and imaging like a CT scan with IV contrast are important in order to arrive at the possibility of a splenic pathology. CBC may be variable, but a CT scan can view evidence of splenic laceration, mass, or abscess well. In the presence of respiratory symptoms accompanied with fever and shortness of breath, CBC and chest X-ray are critical tools in the management of a pulmonary etiology. Leukocytosis and left lower lung lobe infiltrate can confirm a diagnosis of lower lobe pneumonia. An 18-year-old college student is brought to the emergency department due to severe left upper quadrant pain for the past hour. The pain started when someone accidentally hit him in the abdomen while playing rugby. The patient has a past medical history of sore throat and severe fatigue for the past month. Vital signs are significant for a blood pressure of 80/65 and a heart rate of 135. What is the most likely cause of this patient's current symptoms? This 18-year-old college student reports severe left upper quadrant pain for the past hour. The pain started when someone accidentally hit him in the abdomen while playing rugby. The left upper quadrant pain and history of trauma raises suspicion for splenic injury. Additionally, he has a past medical history of sore throat and severe fatigue for the past month. Considering his age, these symptoms are consistent with infectious mononucleosis. Infectious mononucleosis can cause splenomegaly and predispose patient to traumatic splenic rupture. Vital signs are significant for hypotension with the blood pressure of 80/65 and tachycardia with the heart rate of 135. Hemodynamic instability with left upper quadrant pain is most consistent with splenic rupture. Next, we will discuss the etiologies of epigastric abdominal pain. Common etiologies of epigastric pain are abdominal aortic aneurysm, acute pancreatitis, aortic dissection, and peptic ulcer disease. Pain that classically radiates to the back can direct us to a possible diagnosis of AAA, acute pancreatitis, or aortic dissection. Presence of a pulsatile abdominal mass on physical exam needs to be confirmed with an abdominal ultrasound when there is suspicion of an AAA. Aortic dilatation greater than 3 centimeters confirms the diagnosis. Absence of pulsatile mass, with pain still classically radiating to the back, leads us to either a diagnosis of acute pancreatitis or aortic dissection. Presence of nausea and vomiting with history of alcohol abuse or gallstones should be further evaluated with lipase levels and abdominal ultrasound. Lipase 3 times higher than the upper limit, and ultrasound with evidence of gallstones and biliary duct dilation confirms a diagnosis of acute pancreatitis. On the other hand, a tearing pain that radiates to the back calls for a chest X-ray or CT angiography due to suspicion of an aortic dissection. Typically, a chest X-ray reveals widened mediastinum, while CTA shows an intimal flap with double lumen. Pain that does not radiate to the back but presents with pain before or after meals is classic for peptic ulcer disease. History of melena and chronic use of non-steroidal anti-inflammatory drugs are associated with this disease. A positive fecal occult blood test, urea breath test, and a confirmatory esophagogastroduodenoscopy test revealing an ulcer with smooth edges and round base confirm the diagnosis of peptic ulcer disease. A 65-year-old man is brought to the ER due to severe abdominal pain radiating to the back for the past 30 minutes. He's been smoking 3 packs of cigarettes per day for 40 years. His vital signs are significant for a blood pressure of 85/70 and a heart rate of 136. Physical exam reveals epigastric tenderness with pulsatile abdominal mass. What is the best next step in diagnosing this patient? This 65-year-old man reports severe upper abdominal pain radiating to the back for 30 minutes. He has had extensive smoking history predisposing him to vascular disease. His vital signs are significant for hypotension with blood pressure of 85/70 and tachycardia with heart rate of 136. Physical exam reveals epigastric tenderness with pulsatile abdominal mass. All these findings suggest the diagnosis of abdominal aortic aneurysm with possible rupture. The best next step in the diagnosis of this patient is abdominal ultrasound. Abdominal ultrasound typically shows increased abdominal aortic diameter in patients with abdominal aortic aneurysm. Let's move on to etiologies of right lower quadrant and left lower quadrant abdominal pain. The following etiologies can either present with right lower quadrant pain or left lower quadrant pain, but we will note the ones that tend to gravitate towards a certain area more than the other. Let's begin. When a female patient presents with lower quadrant pain, serum beta HCG levels must be collected first. If this is markedly elevated, accompanied with an overdue menstrual period, nausea and vomiting or vaginal bleeding, transvaginal ultrasound must be conducted right away. An empty uterine cavity with free fluid in the pouch of Douglas confirms a ruptured ectopic pregnancy. Absence of elevated beta HCG levels with presence of pain following rigorous activity along with vague constitutional symptoms, also calls for a transvaginal ultrasound due to a possibility of a ruptured ovarian cyst. Evidence of free fluid in the pouch of Douglas can also be seen with this etiology. Presence of right or left lower quadrant pain that is worse before menses should direct to a suspicion of endometriosis. This may present with dysmenorrhea, dyspareunia, dyschezia, and infertility. Transvaginal ultrasound or laparoscopy may be needed as a diagnostic tool. Ultrasound shows evidence of homogeneous ovarian cysts, while laparoscopy reveals endometriosis, implants, and adhesions. A palpable mass also indicates a transvaginal ultrasound with Doppler. Presence of an enlarged ovary with decreased blood flow confirms an ovarian torsion. Pain with presence of purulent or bloody vaginal discharge may be rooted from an infectious disease. If the patient is sexually active with signs of menorrhagia, chandelier sign, dysuria, and fever, then gonococcal and chlamydial PCR and cultures are taken. Positive results confirm a diagnosis of pelvic inflammatory disease. Signs of antalgic gait and tender internal rotation or extension of the hip, accompanied with fever and low back pain, should be further evaluated with CBC, CT and IV contrast, and blood culture or a gram stain due to the possible presence of psoas abscess. With this disease process, presence of leukocytosis and Staphylococcus aureus, as well as encapsulated hypodense lesion with peripheral enhancement on CT, are diagnostic. As we go down this algorithm, let's also focus on what could generally cause a right lower quadrant pain, appendicitis. Pain migrates from the periumbilical area to the right lower quadrant. Fever, nausea, and vomiting and pain along McBurney's point are classic characteristics. CBC and CT with IV contrast reveal leukocytosis and distended appendix with wall thickening, respectively. On the other hand, presence of hematuria, along with dysuria, flank pain, nausea and vomiting, and Koenig sign, directs us to a renal pathology. Urinalysis and non-contrast CT scan are diagnostics used to confirm nephrolithiasis. Urinalysis is usually aseptic with low pH, while CT shows radio-opaque or radiolucent stones in the ureter. On the other hand, pain focal to the left lower quadrant with change in bowel habits and constitutional symptoms should raise suspicion for diverticulitis. Leukocytosis and colonic outpouching and wall thickening are seen on CBC and CT with IV contrast, respectively. A 7-year-old boy is brought to the emergency department by his parents due to vomiting and right lower abdominal pain for the past hour. Vital signs are significant for a temperature of 38 degrees Celsius. Extension and internal rotation of the right hip, as well as palpation of the left lower quadrant, all exacerbate the right lower quadrant pain. What is the best treatment option for this patient? This 7-year-old boy presents with vomiting and right lower abdominal pain for the past hour. His vital signs are significant for a fever of 38 degrees Celsius. Extension and internal rotation of the right hip, as well as palpation of the left lower quadrant, all exacerbate the right lower quadrant pain. Pain exacerbation on extension of the right hip is known as psoas sign. On the other hand, worsening of the pain on internal rotation of the right hip is called obturator sign. Finally, if palpation in the left lower quadrant exacerbates the right lower quadrant pain, this phenomenon is known as roving sign. Positive psoas sign, obturator sign, and roving sign all suggest the diagnosis of acute appendicitis. The best treatment option for acute appendicitis is urgent appendectomy. Let's discuss etiologies of diffuse abdominal pain. Abdominal pain that is diffuse in character is usually correlated to either a small bowel obstruction or ischemic colitis. Signs of obstipation and increased bowel sounds with a history of abdominal surgery can be further evaluated with a kidney, urinary, and bladder X-ray or KUB. A dilated small bowel with decompressed large bowel confirms the diagnosis of small bowel obstruction. On the other hand, presence of hematochezia and pain out of proportion to physical exam are classic signs of ischemic colitis, especially with recent abdominal surgery. Diagnostic imaging include KUB and CT with IV contrast showing evidence of an air-filled distended bowel and pneumatosis intestinalis, respectively. Lastly, we'll discuss acute abdomen. An acute abdomen is described as severe abdominal pain with acute onset, usually less than 5 days. A thorough history and physical exam guides the evaluation. Moreover, peritoneal signs such as abdominal guarding and rigidity, along with shock, call for immediate intervention. An acute abdomen is diagnosed clinically. A presentation of tender abdomen with guarding and rigidity, along with absent bowel sounds, should raise suspicion. Further imaging can help with diagnosis. Evidence of perforation is seen on abdominal X-ray as free air under the diaphragm. If results are inconclusive, abdominal CT scan confirms the diagnosis. Lastly, for female patients, pelvic ultrasound is a diagnostic tool commonly used when serum levels are positive for beta-HCG. This is to prevent exposure to radiation that is toxic to embryo. Management of an acute abdomen depends on the patient's presentation. Emergent laparotomy is indicated in hemodynamically unstable patients. Keep in mind that the ABCs, or airway, breathing, and circulation, are also part of the initial management. Hemodynamically stable patients, however, have more time for evaluation. Focusing on treating the underlying cause is important. Patients must be on NPO or nothing by mouth. In addition, placing a nasogastric tube along with intravenous fluids and a Foley catheter are indicated for stabilization. Frequent abdominal exams and serial scans to evaluate probable worsening of an acute abdomen are critical. Lastly, medications like parenteral analgesics and antiemetics, as well as empiric antibiotic therapy, are often provided while trying to figure out the underlying cause. Let's end our lecture with a board-style question. A 25-year-old woman is brought to the emergency department due to vomiting and diffuse abdominal pain for the past 4 hours. Her past medical history includes laparoscopy for ruptured ectopic pregnancy 2 years ago. Her vital signs include a temperature of 40 degrees Celsius, a blood pressure of 80 over 60, heart rate of 155, and respiratory rate of 16. The physical exam reveals diffuse abdominal pain with rebound tenderness, rigidity, and guarding. Serum beta-HCG is undetectable. The abdominal X-ray reveals dilated bowel loops and air fluid levels, along with air under the diaphragm. Intravenous fluids and antibiotics are promptly initiated. Which of the following is the best next step in managing this patient? A. Pelvic ultrasound. B. Abdominal CT. C. IV metoclopramide. D. Emergent laparotomy. This 25-year-old woman presents with vomiting and diffuse abdominal pain for the past 4 hours. Her past medical history includes laparoscopy for ruptured ectopic pregnancy 2 years ago. Previous abdominal surgery predisposes the patients to abdominal adhesions and bowel obstruction. Her vital signs include a fever of 40 degrees Celsius, hypotension with the blood pressure of 80 over 60, and tachycardia with heart rate of 155. These values indicate that this patient is hemodynamically unstable. The physical exam reveals diffuse abdominal pain with rebound tenderness, rigidity, and guarding, findings consistent with an acute abdomen and peritonitis. The abdominal X-ray reveals dilated bowel loops and air fluid levels, along with air under the diaphragm. These clues indicate the small bowel obstruction as well as the bowel rupture and pneumoperitoneum. The best next step in the management of hemodynamically unstable patient with acute abdomen is emergent laparotomy. Therefore, the correct answer is option D. Here's a slide reminding us of the management of an acute abdomen. Pause the video and take a moment to consider the slide once more. Let's discuss why other options are incorrect. Option A is incorrect because although this patient is at risk of ectopic pregnancy based on her past history, serum beta-HCG is undetectable, making this diagnosis unlikely. Plus, patient is hemodynamically unstable and requires emergency intervention without wasting time. Option B is incorrect because abdominal CT scan will not change the management of this patient. She will require laparotomy, so performing CT scan in this particular case would waste time. Finally, option C is incorrect because although this patient needs antiemetic for vomiting, metoclopramide is contraindicated in patients with bowel obstruction. This is because metoclopramide increases GI motility and exacerbates the symptoms of bowel obstruction. And that concludes our lecture on abdominal pain.